Welcome back to the Shared Practices podcast. I'm Caitlin Embree, and I'm joined today by Dr. Andrew Clingan. Welcome back to the show.
Hey, Caitlin. It's good to see you on this format. It's
It
been too
is.
long.
It is. Yes. Normally we're doing coaching calls together and talking about your practice. So we're doing a little diversion today that I'm excited about.
I am too. I have to be honest, I miss my days of regular podcasting. My buddy and I, Steven, ran TPO for so long, and we had a generational run, I would call that, back in the day. But my life has been more focused on practice ownership the last 2.5 years. So it's nice just to get back on here and run my mouth for a little while on a podcast.
Absolutely. And we get to kind of tap into the wisdom that you've gained over these last couple of years of being a real-time practicing dentist and
Yeah.
all the
Some
highs
call
and
it wisdom,
lows.
some call it trauma,
Right.
whatever
Right.
however you want to frame it.
Well, we're here to share it all with our audience today. And, you and I got together. We're like, what could we really bring value to on the show for today? And I think we both share a love for talking about case acceptance. We did a course in Scottsdale together not too long ago, this past fall, and I had the opportunity to sit in the room as you presented to dentists about, increasing their confidence, increasing their clarity. And I got to kind of be a heckler in the back and fill in the gaps there. So that was really fulfilling. And I think it's cool for us to kind of transition that conversation on air today for our listeners.
Yeah, absolutely. I think this is one of the lowest pieces of hanging fruit you can go after as a dentist to move the needle in your practice. I mean, it's tempting to go, hey, go learn all these big time skills, learn all on four, learn clear aligners, learn molar endo. But the reality is in dentistry, patients don't know how good you are clinically, right? And it really doesn't matter how good you are clinically if you can't connect with patients enough to get them to listen to your recommendations. And there's a lot of places we can go from that with mindset. I think most people, when they hear case acceptance, they automatically go, well, give me the words to say. I need a script. How do I phrase this to a patient? And I would say, yes, words matter, but that's a very small percentage of the pie, if you think of it as like a pie chart in your head. I think mindset's a big part of it. I think your confidence going in, what you believe about your role as their provider and their dentist means a lot. And then, words do matter, and how we treat the patients and how our team treats the patients really matters. And there's a lot of things that the team can do to roll that proverbial stone up the hill or the mountain. I know that's the analogy you like, and the doctor just comes and tips it over. Mm-hmm. There's a lot of directions we can go with this.
When I was thinking about what I wanted to focus on today, a lot of the themes in my coaching calls lately have been about objections, how to handle them when we get them, where do they come from? And so just kind of to start us off, I'm trying to lean into the fact that we don't want to avoid objections. Let's just assume, when we're going to present some treatment to a patient, both clinically and from the financial arrangements perspective, there probably will be an objection, and let's not think of it as like a bad thing or a rejection. No. Let's expect that from patients and be prepared to kind of turn that into a yes by being curious about where that objection actually comes from.
Yeah, I think this is a unique opportunity for doctors and their teams to kind of lean in and gain a lot of patient trust. It's not them rejecting you. And honestly, you'd rather have the objection conversations and be able to talk to them on the front end than rather on the back end when something goes wrong. Mm-hmm. Or when it costs more than they anticipated. Mm-hmm. And really what we don't want to do, we've all heard the stories of the big bad corporate dentistry where they just kind of shuffle patients in and out and tell them, this is what you have to do because I said so. Here, sign on the dot. You're going to get a deal today that you'll never have again. And the patient just is like, well, I guess I got to do it. And they're confused the whole time. Yeah. That happens. I had somebody come to me last week for a second opinion with that essential story. It's I don't know. And so, the whole objection thing, that's a great point. It's not a thing that we should get defensive about. We should look at it like an opportunity because that is the spot where we can earn a lot of trust. We can show them our expertise. We can show them that we're an easygoing person. And really what it comes down to when we have objections, there's 3 or 4 main categories of that for most people. And for a doctor, a lot of it comes down to is listening to what they're saying and realizing, okay, what are they really asking here?
Let's get to what's actually underneath that objection, because
Yeah,
often it is not very obvious with the words that they are saying. So, what this sounds like in an exam, if we were to just kind of switch some verbiage around, I think I like to make sure that our doctors are gaining a yes from the patient before they leave the room. Are you and the patient on the same page, in agreement that this needs to take place? That's the next step. And you feel as though there's a yes from the patient. Obviously, there's more steps to happen with financial arrangements and scheduling. But from
sure.
clinician, from your perspective as a doctor, before you leave the room, do you think the patient is a yes for this and they understand what they need and why? And if the patient is not a blaring obvious yes, one of my favorite kind of verbiage shifts is, I think a lot of times a doctor might say, "Do you have any questions for me or anything?" And they'll be shaking their head no as they ask that question. And then their body language, what they don't mean to, but their body language is like, "Don't have any questions. I got to get into this next exam. I got to get in and finish this crown up." So rather than that, it's like, to almost invite these questions from your
Yeah,
patients, and in order to get to that objection, if there is one, is, what questions do you have for me?
exactly. That's the phrase I use in my practice. I never go, is there or excuse me. It's so ingrained in me now. I say, what questions do you have? I never
Yes.
ask, do you have questions?
Yeah.
So that's just a real simple spot. It creates space. And on that point, I think dentists would do better just to feel comfortable enough to create space in these conversations. And what do I mean when I say create space? Like, quit talking some. Be comfortable with a little bit of silence. We get nervous, and so we automatically start speeding up. And when we as dentists get nervous, we fall back on what's inherent in us, and that's our training in dental school. And so, oh yeah, the patient is confused on why they need a crown, and all of a sudden Dr. So-and-so is talking about the wear resistance and the strength of zirconia. Like, that's
Yeah.
not helping. It's not
Resulting
helping at all.
to dental jargon, right?
Yeah, I
Yeah.
promise. Like, their objection is not in the strength of your restorative materials. They may want to know, like, how long is this going to last? Is it going to hurt? If they're asking a lot of questions about insurance, what they're really saying is, am I going to be able to afford this?
Right. Right.
And yeah, I just love that. Like, let's be on the same page before we leave the room. That doesn't mean we necessarily bully them into an answer. Some people need to genuinely think about it. I don't like that excuse, but they genuinely need to think about it, or genuinely need to talk to a spouse. But when you do this enough, you can start to read like the body language to go, okay, this person's with me or they're not. Right. And the reality is, you're not going to get 100% of people on board in the chair. But if you can get 80 to 90% at least understanding what you're saying, at least interacting and engaging with you. Yeah, there's always going to be the 10% that are trying to run off to work, or they're having a family crisis that day, or they just don't really respect dentists as healthcare providers, whatever that may be. But most people, like, yeah. And so I always go, yeah, do you have questions? One thing I say a lot is just, what gaps can I fill for you? What did I not explain well? Hey, does that make sense to you? And I'm trying to ask these questions that elicit a response, because like you said, if we can go back and forth a little bit in this, then yeah, we're on the same page before we leave the room. And there's still a few things we have to do to push that boulder over the mountain. But at least at that point, the patient's not confused, right?
And
They know what's happening.
Right. And even if we were to back up a few steps in the asking questions aspect of the exam and create more space, I love that kind of framework. It's even when you're looking at a tooth going, I know this is going to need a crown. I know this is going to need a filling. I'm prepared to have that conversation. The x-ray is making that obvious. Asking a question to the patient as you're tapping on that tooth, or you're showing them the photo or showing them the x-ray. Hey, does this bother you? Do you get food stuck here, or are you having any sensitivity here? That might lead the patient to think about that and go, yeah, now that you mention it, yes. Yeah. And that prepares them better for you showed me a problem, and now you're going to inform me of why that problem exists. Now I'm more open to understanding my need. And it's mitigating those objections before they come up, because one of the underlying objections is, I don't believe you that I need this. I don't
It
know
doesn't
if I need
hurt.
this. And so the more kind of like silence you can sit with is such good advice. And I work on this too as a coach. Same kind of idea of I want to get on my coaching calls and I want to provide solutions for my clients and I want to guide them to what they can do to get to their vision and solve their problems. And that's the former OM in me of like, I just want to fix it, you know? And, but as a coach, it's like, you need to be calm. And that's actually the confidence there is to calmly lead someone to go, well, like, how does that feel for you? Does it bother you that you have to respond this way? You know, asking more questions, it truly does get to a better response, and less objections in the first place.
Yeah, and if I could even back up just a little bit more, I think to be able to do this, there has to be a little bit of like confidence in yourself and swagger. And, you know, you never want to be the arrogant person in the room who you do this because I said so kind of provider. But here's like the more time I spend in dentistry, and for what it's worth, I haven't been in the field for 20 years, but the more time I spend, I think there's this persona of a dentist that people are so afraid of being. That's the overdiagnoser. That's the money hungry person. That's kind of like the bully in the operatory. That we're so afraid of like this fringe 3% of dentists out there that we swing so far on the other side of the spectrum as dentists, and we sometimes do our patients a disservice. So I think like the first part is just recognizing that if you're like worrying about this stuff, you're probably well intentioned. Our job comes down to a lot of judgment calls. I tell patients that all the time. Disease happens on a spectrum. The minute they come to me and they go, well, when I was a kid, one dentist told me I had 10 cavities and the other one said I only had 3. And I just tell them, we have to make a lot of judgment calls. And there are some people who want to take advantage of you, but most people really don't, you know? And so I think this has to be kind of grounded in the identity, and you have to be comfortable that your role as a doctor doesn't really change depending on the money or depending on the pressure. Like, I felt that a lot early on. I'm like, oh gosh, I see like 6 or 7 teeth. I can only tell them about 2 because they're going to think, you know, I'm money hungry, or they're going to think I'm more aggressive than the older guy, right? And the phrase that I tell my team a lot, and you probably know exactly what I'm about to say, is that we as dentists never took an oath to save anybody money. We took an oath to tell them the truth, like veracity. You remember those questions on the boards, right? We took an oath to do no harm. And so I think a lot has to go in mindset work on the front, even though this sounds like a little corny and ethereal to say. I think you have to go through these mental gymnastics as the dentist on the front end to walk in there and just have the confidence and the conviction in what you're doing enough to go, hey, here's what it is, regardless of the consequences. And that's the most ethical thing we can do. We're not being ethical by saving people money. I mean, I want to save people money. I get it. Like, there's 2 things I always tell people that are like the worst thing to spend our dollars on. That's car repair and tooth repair. Okay. Like, it's just not fun, but we like driving, we like eating. So it's a worthwhile investment. And our job as a clinician, and this is something I really have to like preach to my hygienist with perio, is like we're given the opportunity to help people with their health, right? And if we're afraid to tell them the truth because we're going to be keyed as the overdiagnoser, or they're going to think that we're trying to take money from them, we don't need to be in the profession because we're not doing our job fully. And so for me, once I kind of like came to terms with that, this stuff that you and I are talking about became a lot easier for me because once again, I had confidence and conviction in what I was doing. Now, does that mean I'm right every time? No. I'm like any dentist. Sometimes I open up a tooth and it's not nearly as bad as I thought it was going to be. But there's plenty of times I open up a tooth and it's way worse, right? And so we have to do our best to make that judgment. I'm very upfront with the patient. Sometimes things don't hurt. Their objection is, you're telling me I need $1,000 crown, Dr. Clingan, but shouldn't this be hurting? Hey, great question. Things are not always symptomatic, but there could be a problem there. The same goes with the heart attack. How many people have clogged arteries but don't have symptoms yet, right? And I can have these candid, honest conversations with people because I can sleep at night knowing what I'm doing is I'm being honest. I'm not perfect. I definitely misdiagnose things sometimes on both ends of the spectrum because I'm human. I have AI that helps me, sure, but like I'm human, and so I miss things on both ends of the spectrum. But I can sleep at night with my recommendations knowing, one, I'm doing the best I can to be good at my craft, and two, like, I just stay unattached from the money and the pressure and the social part of that, and just go, hey, my job is to be a clinician.
Absolutely. And I think from the patient's perspective, you want your clinical providers, your dentist, your hygienist, you want them staying in the clinical space and not in the financial space. I always say, like, set your systems up well enough with your front office team that you can trust that when it's time for the financial conversation, the insurance questions, whatever comes their way, and we'll get into that, that transition will be smooth, and there's somebody else who can talk money and help
Sure.
them navigate, how do I afford this? Because one of the main objections is cost. We all know that. That's
Always.
not always the objection, but it is a very common one.
70%. Yeah.
Yep. Okay. So, it's tempting as providers to already be thinking about that because that's so common, but you have to actively put that out of your head and say, if this was the family member in my chair, what would I be recommending? And, you
Exactly.
mentioned the heart, and that's an analogy I make often about, hey, as a dentist and as a hygienist, let's tell them the whole story. Suzanne gave me this a long time ago. She goes, how would you feel if you went to the cardiologist and they didn't give you the whole story? You think you're being the good guy maybe by not giving the bad news and not being 100% honest about what
It's
you're
easier
seeing.
because people like us. It's easier, but
Yeah.
we're not doing them any favors.
Right, exactly. So, I think the best thing that we can do is build some core values with our team about patient care where we're all on the same page. We're going to be honest, we're going to be compassionate, we're going to tell the whole story, we're going to get to the objection, and we're also going to have really great verbiage and transitions and, options in place so that, let's say cost is the objection, we have solutions for that patient to help them
Sure.
afford that treatment, whatever that might look like.
On the cost thing, so one area that I've really changed my approach in the last year and grown is I used to kind of play like the doctor that didn't know I played ignorant to finances, if that makes sense. So patients are going to ask me, well, how much is this going to cost, right? And I go, oh, I don't know. Like, I don't know what your insurance is. Like, I don't know, like, the numbers inside of my business, right?
Right.
And what I found a lot of times is I got the yes and the operatory, but because they had no, like, frame of reference to
Right.
finances, they got to the front desk and they got sticker shock, and people would walk out. And I'd have my front desk tell me all the time, like, Dr. Clingan, you charm them in the back and they're ready to go until they find out how much it's going to cost, right? And I think there's a few things. One, two, I don't really love big financial presentations at the front desk. The way our practice is set up, it's kind of what we have to do, but that's a conversation for another day. But the approach that I've changed is now when they ask, hey, how much is this going to cost? I just go, hey, this is the round, like, typically a crown is $1,000. And I see them raise, but a lot of insurances pay, and some people's out of pockets is, as little as $300 or $400 at times. It can sway a bunch. There's lots of ways we can get the job done, and they're the experts. Don't listen to me. They may tell you whatever they say up front, you listen to them, and they have flexible ways to get the job done. But what is happening right there, and this is like the big thing that's kind of my focus right now, and I'm learning a lot about, and I'm wanting to teach my hygienist and associate about, is most of case acceptance, these conversations I visualize, and this is not my original idea, there's two spectrums. There's like the emotional spectrum and the rapport spectrum, and then there's like the objective scientific. The reality is most of case acceptance lives in that emotional rapport type conversation and questions. It's not in the some people will ask, well, what does a crown involve? And I just dumb it down and say, hey, we remove the damage to the tooth, we repair that, and then we shape the tooth for a cap to go on top of it that protects it. And they're like, oh, okay, cool. You're numb, you don't feel a thing. But what I'm really like taking the opportunity to do, whether it's that or whether it's the conversation or the financial conversation or the pain and fear is I'm trying to hear what they're really getting at, right? So when they go, how much does a crown cost? I'm not trying to be objective and be like, well, Mr. So-and-so, our crown fee is $13.94, and sometimes we do a gingivectomy, but sometimes we don't, and sometimes we do a build-up, but sometimes we don't, and your insurance pays 50%, but let's see, do you have a waiting period? Like, they're not wanting to know all that. They're just wanting to know, can I afford this, right? And so we'll get into the nitty-gritties because, yeah, waiting periods and if a crown was done less than 5 years, like that stuff matters. You know, their patient bill can swing by a few $100s if we don't get that stuff right at the front desk. But in the operatory, like they're not wanting the objective analytical answer. They're just wanting to know, like, is this like affordable for the average person here, right? And so I just try to hear that and go and address it. If it's about pain, hey, I hear what you're saying is you're afraid of the dentist, and I get it. Like this, I always joke with people. I said, unfortunately, it's not a spa day. It's not a day at Disney World, but it's necessary stuff, and we work really hard to keep you comfortable the entire time. I go at your pace. If you need breaks, I'll take it. And I try to enter in that with them and realize, okay, where are we on the spectrum? Are they really wanting like the objective facts? And sometimes they do. Sometimes I'll have like an engineer in my chair who wants to really discuss like milling and 3D printing with me. And that's fun because I get to nerd out with them for a few minutes. But most people are not asking that. They're just wanting to know like, what's this going to cost? How long am I going to have to take off work? Is it going to hurt me? How long is it going to last?
Yep.
And you would be very like shocked at just how low dental IQ is in the general population, even for educated people.
Absolutely.
Right?
And that's our
most
job.
Most people, when I tell them they're getting a crown, think they're automatically getting a root canal in a crown. So they'll go, hey, Miss Jones, you need a crown. Does this mean you're removing my roots? I'm like, no, that doesn't mean that, right? So that's really where I'm at right now is I'm trying to go, okay, what are they really saying? And I'm trying to build that rapport. And what it really helps to do, the second level of this, is you learn to swap in between these two spectrums in the conversation between the objective stuff, because you can show that you're an expert in this to people. You don't need to go too deep into all the scientific stuff, but you can go, yeah, Miss Jones, I hear what you're saying. I tell people all the time, there's a lot of things that go into how long this crown is going to last for you. How good of a job I do, how good of a job you do taking care of it, how good of a job Mother Nature does. The reality is when we do this well, this material lasts for 10 to 15, 20 years, and it's getting better and better. But essentially, you can rest assured I'm going to show up and I'm going to work as hard for you as I can. As long as you can keep the tooth clean, like this tooth has a good long-term outlook, right? And this is like the fun part for me. The whole idea of case acceptance, it's more than just a script. It's more than just say these words. It's learning human behavior and interactions and ultimately how to get people to trust you more. I think for teams, like we hear case acceptance, and I would love to hear your thoughts on this, but the idea around tracking case acceptance dollars, teams very quickly go down the road of, oh, they're just trying to squeeze more money out of the patients, out of this place. When in reality, we had our annual team meeting, like big one the other day, and we looked at our mission statement and values, and my OM goes, what's on this mission statement that you guys don't think we do well? And of course, no one really wanted to speak up because like it feels like they're criticizing the boss, right, when they do that. But one of my team members said, hey, this talks about like we're trustworthy and people trust our recommendations. I think there's some things we could do to be better at them like trusting what we say. Bingo.
Okay. Yeah. And that's takes courage to hear out your team and listen to that and go, okay, so that's the way you're experiencing it. Imagine how the patients are experiencing it. So, the team is your window into your patient's objections and their trust for you, because when you walk out of the room, they're turning around and looking at the hygienist, looking at the assistant and going, well, what do you think?
I really need this?
Yes, exactly. And I want to double click on, we've covered cost is of course really common, but fear is also super common. And that one isn't going to be as obvious. It's not going to be, I'm terrified of this, so I'll call you guys when I'm less terrified. It's going to sound more like, oh, I need to think about it. Let me check my work schedule. It's going to be a little bit more vague. And
how long is this going to take?
Yeah. And so, finding that to be the true objection, that then that way you know where to explain more. Because if you start assuming the objection is cost and you go down a big spiel about ballpark figures and insurance coverage, when that is not the issue whatsoever, and it's more so, something else related to fear, then you're solving for the wrong issue, and you're not building up that trust. It's just jargon in their minds. You're just over explaining something that doesn't need to be explained, right? And so, I think it's important to explain to the patient like what that appointment is actually going to feel like from start to finish. Like when we say, hey, we're going to keep you super comfortable, like we might go into detail about, honestly, most of my patients say the worst part of the appointment is just getting numb in the first place. Like no one likes needles. We get that. But obviously you got to pick between the lesser of two evils. We want you nice and comfortable, nice and numb. After that, you're just going to feel pressure, And so they need those details of, yes, how long is it going to take? But are they just asking that? Or are they asking like, how long am I going to be really, really uncomfortable here? And so just normalizing that fear and not making them feel silly. Like you touched on dental IQ, and it's so true. And especially front office teams too. I'm always talking about the new patient phone call. Don't assume patients understand their dental insurance. Don't assume they understand what a first visit entails. It's our job to educate on that in a non-condescending way, and just say, hey,
Sure.
this is what it means to be a patient at our practice. This is how you get started. So we have to constantly be on stage for our patients and bridging that gap, so we can build that trust.
Yeah. And that's what this is at the end of the day. Like I said, one of my things, it's easy to hear me on this podcast be like, I'm not concerned about money, regardless of whatever. But the reality is, if you run a run practice and have good operations and do a halfway decent job at this stuff and have the patient flow, the money will just trickle down. Like practice management's just a numbers game, right? It's a patient flow game, a diagnosis, an acceptance, and a collections game, right? And so that stuff really takes care of itself. That's something I kind of preach to my team. That's why we don't measure like success typically in collections. We measure it in some of the more upstream analytics that we track in PBN.
Yeah.
But yeah, at the end of the day, this is about people trusting us. And if you're a private practice owner these days, there is, in my opinion, never been a better time in the history of dentistry to work on patients trusting us. Okay. I love to knock on corporate dentistry for a second. Left and right, like people are waking up and seeing like in America of not just in dentistry, but other things. Like you see comments online of like private equity ruined this dentistry.
Yeah.
Oh, when private equity came in, we got upsold on everything. And they're starting to say the same thing about dentistry. And I'm not saying every dentist that works for a DSO is bad. There's good dentists, but you have this is your unique selling point. Okay. If you're in an area with like a bunch of corporate, it's not that they don't have good doctors there. That's not what I'm saying. But like you have this very unique opportunity to be like, oh, we're the place people trust. We're the place they send their mom. And this is part of that exchange. It's not, they're never going to say Dr. Clingan's crown margins are sealed shut within 0.002 microns. No one's ever going to utter that, okay?
Right.
Like we lose sleep over that at night as dentists, but no one's ever going to, and don't do bad dentistry. That's not good for anybody. But no, like go look at my Google reviews. I think I get a clinical compliment 1 out of every 10 to 15. Now, those make me feel good because I work hard at being very good clinically. But they go, oh, they listen to me. The staff is so friendly and welcoming. Mm-hmm. Oh, they're honest. And here's the thing, like when you do this and you create space in this consult and you answer the objections like with honesty and humility, people very quickly see in like behind the curtains and into you and be like, okay, this person's like actually pretty humble and they're just trying to do the best they can. Like when they have objections, sometimes the best thing I can do is acknowledge that that's a very valid objection. Yeah, like sometimes dentistry, we do our best to keep you comfortable. It's inherently an uncomfortable procedure. You have to hold open for me. It's in the very back of your mouth. I have to spray a lot of water. Like I get that. But here's what we do to try to help with that. And believe it or not, when you actually acknowledge them and be like, hey, you're not being a baby. This is legit. Or you're not being cheap. Yes, dentistry is expensive because it is. They go, oh, like this person's just trying to tell me the truth. And it creates more and more of these areas of micro trust that you can build up with the patient.
Absolutely. That all adds up. I love that micro trust. And you mentioned AI earlier, and I think we would be remiss not to kind of take this conversation into the areas in which technology can help this whole process soar. Hopefully
Sure.
at this point in the game, a lot of our listeners, those who own their own practices and have been able to make changes to technology, I hope that everyone is using an intraoral camera photo. I'm hoping that we're all taking IO photos, multiple of them, and I'm hoping that we're holding our hygienists accountable to take those at every visit and the new patient appointment. There should be protocol for that. Second to that, I'm hoping that even more of us, maybe not all of us, have a scanner in place that we're using. That's going to be a little bit less common than the IOs, but a lot
Yeah.
of practices at this point, though, it's a little bit easier of an entry than it ever has been to get a scanner in place, right? So
Hmm.
that's kind of step 2 in my book, and step 3 is now the AI for radiographs, whether it's Pearl or Overjet. George has touched on this a lot. Is becoming the new norm as well, and so I think a few years from now that'll be just as normal as the intraoral camera photos. But this is truly like a picture says 1,000 words, and nothing helps you push that boulder over the mountain, like you mentioned,
Hmm.
than just having the patient staring at that crack line on the photo the whole time they're waiting for you to come in for the exam, and just training your team like, hey, while you're waiting for me, bring up those photos in front of them so they can look at the bleeding, they can look at the discoloration. So when I come in, I can point to it and go, does that bother you?
Yeah, this is the part too that's very fun for me because there's a huge spectrum on this, like utilizing technology for illustrative purposes. And this is like a big like focus we've had in our practice. So yeah, like the baby step, the first step is intraoral photos. Go get a $200 mouthwatch camera, okay?
Like there's almost no excuse whatsoever to not have
No,
that. Yeah.
no. I mean, it's kind of like,
Yeah.
yeah, at this point, it's kind of like somebody having paper charts
And
still.
hold your
Like, just
team
don't.
accountable to using it.
Yes. But then there's like the other far extreme, and we've started to dive into this pool of like you have in-office printing and exocad design, and we're starting to print out like trial smiles for people to pop in.
Right.
Like, and what I would encourage people, that sounds really fun, and it is, I'll admit, it's
Yeah.
very fun. And I think there's people who hold whole case acceptance courses that talk about the extra oral photos and these designs and doing bigger dentistry. Like walk before you run is my encouragement to you. So like I think the easiest thing is the intraoral photos. That speaks for itself. Like take a picture of something. And the one thing, and it's easy for me to preach this on my podcast, but we're still working on my practice, is like when you come in, that the hygienist has done this stuff and they've talked to the patient. And then when I ask how the patient's doing, dear God, please don't say they look great when they have a big crack on a tooth back there. Go, hey, everything looks good, but I have this one concern, right? Like,
Right.
and
Right.
so we might get into co-diagnosis in a minute, maybe not. But the easiest thing I think is the intraoral photo. I actually think instead of the scanner, I think the second easiest thing is actually the AI to integrate because everybody's pretty good with x-rays. We've been using AI. We use Pearl in my practice. I think most of them do a pretty good job. We've probably been using that for, it feels like forever, but only a
No, it
year.
hasn't been very long. And
Only a year.
yeah, yeah. And, we won't go into too much detail about it. Go get a demo with one of these
Sure.
companies and you'll see. But like, what's really, I think, the most impactful is the patient education aspect of this. That is why
I
a
tell
lot of
people-
us are getting it in place.
I tell people all the time. Sometimes it does catch things that I would have missed, especially some proximal stuff. And sometimes I'm like, ooh, is that? And
Yeah.
I would say 9 times out of 10, I open it up. I'm like, oh, it was right.
Right. Right.
There are false positives, but we're not going to talk about that. It's definitely the patient education. We as dentists, like this is once again, we drive in this like objective lane when we're talking to people. Oh, they have an objection. Let me teach them about the different shades of gray on this
Yeah.
screen.
Yeah.
You see this? This is your nerve. And you're like, no.
Yeah.
But I can click one button. I go, you see that little pink spot there? That's a cavity. It's made it to the inner part of the tooth. It's this far away from your nerve. And this is, if you're really wanting to work on co-diagnosis, this is the easiest thing for your hygienist to do. And so, yeah, for me, the AI on x-rays, if you take a good bite wing, it's spot on. There's a little bit of training that needs to happen with your hygiene team around like spotting false positive. These
Yeah.
things are not good with angles. They're not as great with PAs.
Okay.
Sometimes it's tough around like margins or crown. That's just training. But like for interproximal decay, it's really better than I am as a dentist. And so that's just easy for them to show the patient and illustrate, and we don't have to guess if they understand what we're doing. I have not tracked this. My guess in the year I've been using it, I bet you there's like a 20 times ROI on it of what I spend every month.
That's amazing. And is it your experience that you can look at the x-rays historically from before you had the software installed and see the changes that have occurred? Yeah. So that's really powerful. You know, that's the same reason I want those IO photos is I want us to get a baseline when the patient's a new patient. And
I can click one button and, you know, if they've come back in and they didn't listen to my recommendations, I can click one button and go, hey, this was a year ago. This is today. Do you see the size difference?
Yes.
And they're like, yeah. I was like, we do this again, it's going to be at the nerve and you're going to be getting a root canal and a crown.
Mm-hmm. And this touches on, I think, another common objection. It's kind of the least strong objection is it's just a not right now from the patient where they're like, I get it. Yeah, I'll get around to it. They're just not valuing the urgency. They're not valuing the timeline. And a lot of times I'm telling dentists you need to really be careful about setting those timeline expectations with your patients. If it is in fact urgent or the next step on their treatment plan, I want you to say, not whenever you're ready, but it's, hey, within the next 2 months, I'd like to take care of this before it gets worse, if that's the case for you, right? But in order to kind of convey that urgency, you know, either showing the baseline, this was the photo and the x-ray a year ago versus this is what it is now, or using AI, you know, you're using that technology to show the patient, this is why this is becoming more urgent because we've seen the progression over the last year.
Sure. I have a few things to say about this. One, I always tell people, like, I think I said it earlier in the podcast episode, disease happens on a spectrum. You don't wake up with 90% clogged arteries overnight. It doesn't mean that there wasn't an issue in your 30s with your diet though, right? So I'm very honest with people. I tell them, hey, we work hard to identify things early. The earlier we get to it, it's going to be a lot easier. It's going to have a better prognosis. It's going to be cheaper and take less time and discomfort. All we're doing by waiting is just giving it time to get worse and more expensive, you know, or hurt worse maybe. But still always the inevitable question is, hey doc, can this wait? And I'm just honest with some people. If it's active decay, I go, yeah, you could. I've seen some people in 6 months that this grows just a little bit and it's not a big deal. I've also seen some people who played with fire and got burned and they got a root canal. What do you want to do? I make more money on a root canal personally, but you know, what do you want to do?
You say it just like that.
I don't say it like that, but that's my internal monologue. Is I'm like,
but you're like, hey, I can't make this.
I don't care what you do.
I don't have a crystal ball, so you know, I can't.
I use that a lot. As I tell people, especially with cracks in teeth, I'm like, hey, if I had a crystal ball, my job would be a lot easier, but I don't. And so I just tell people cracks in teeth can be stable for a long time, seemingly on the surface, until you wake up one day and that tooth splits in two, and now you're getting a $5,000 implant. Mm-hmm. I tell people I don't go chase every little fracture and craze line in my practice. If I did, I'd have to work 7 days a week to fix them all. But when they start to look a little bit scarier, or there's a bigger tooth, bigger filling or whatever, I go, this is when I start to tell people I can't guarantee what's going to happen to this tooth. And we might wait and it might be fun, or you might wait and you might get burned. What do you want to do? Mm-hmm. And whatever they choose to do, I'm cool with.
Yeah, and this is kind of the other side of the trust and the acceptance is also being unattached to the outcome. And the patient can pick up on that. So you do your part as the educator. You tell them the truth. You tell them the whole story. You use technology to help you with that. And then you get out of your own way. And after you've made sure that you've answered questions and gotten to any sort of objections as best as you can, you say, okay, when you're ready, I'm ready. We'll be here for you. You know?
I like doing crowns. I also like doing implants, whatever you want to do. Like I got an implant on my schedule next week that a year ago I looked at a guy and said, you need to put a crown on this tooth. And he showed up about 3 months later and the tooth was split down the middle. Mm-hmm. He's like, is this the one you told me about? I said, yes, sir, it is.
Yeah. And so you're just like, hey, I want to avoid this for you.
And those are the best days as a dentist because you're like, told you so.
Okay.
Not really. Not really.
I'm trying to reel you in and you're just going for it. I'm like, no, but we really care. We want to be.
I do. I don't like seeing that happen to anybody. But you are lying right now if you don't go, it's nice to be right, you know.
I'm sure the audience can relate 100%.
I promise they can.
100%.
And if you're saying no, y'all need to be honest. I'm the only one being honest out here right now.
Yeah.
But back to the other thing, all the time. Hey, can this wait? And the biggest one I see is like people that need a tooth taken out or something, right? It's not hurting yet. Maybe there's a little infection down around the root. And the term I've started using, I look at them, I go, do you want me to like be a doctor right now or tell you what you want to hear? And that question kind of catches them off guard.
You're like, I want my doctor to be honest with me. You know, I have enough people to tell me what I want to hear.
Yeah, I don't lead with that. That's a little aggressive.
Yeah,
but if you
have that relationship,
or I've had somebody who's been a little like resistant in the past, and I've told them, and they need to get that tooth out. Well, how long can I wait? And I just go, do you want me to be a doctor or just say whatever? Because the reality is, I don't know, but unchecked infection could kill you. Probably won't, but it could. And I can't make promises. So it's my job to let you know that this is here and everything going on. Yeah. You know, because if I don't, I'm on the hook. There's this term called supervised neglect.
Absolutely.
Right. And I don't like bully people or try to scare them. But at the same time, my job's not to be like, oh, it'll probably be fine. I don't know that.
No, you can't make that promise.
No. And so I'm just honest with them. You know, the classic thing we get towards the end of the year is, hey, doc, can this wait till January? Right. And I'll be honest, some people I look at and I go, you know, I can't make any guarantees, but probably it'll probably be okay. Right. Like,
and that builds trust because you're not, it's not every time everything is the sky is falling, you know.
And the other thing too, this is why I make a real big point to always educate them, because it also builds trust when I look at a tooth and go, hey, you got this little thing going on. I think this is going to need treatment in the future. It's not quite crossed that threshold today. I tell them, hey, this happens on a spectrum. Typically, we don't try to wait too late, but we don't try to treat it too early. We try to find this one little spot. You're not there yet. Might be next time, but
you're planting the seed.
We'll cross that bridge when we get there. And they go, oh, thanks for not recommending anything that you don't think I need right now.
Right. Absolutely. It's building trust. And I think you do that by that's another example you mentioned earlier. I love that term of micro trust, of just these little...
It's just being honest.
You know, and what you see today. But being honest goes both ways. It's being honest on the reality side of, hey, if you were a family member in my chair, I'd be moving forward with this today. And then it's also being honest on the conservative side of, if you're a family member in my chair, I'd say, let's not open up this tooth yet. It's not worth it. So, you know, obviously we could just talk for hours about case acceptance and there's so many different layers to it. And we've done episodes in the past and we'll do more in the future. And you know, I would love for you all to reach out and let us know if there's certain, you know, parts of this conversation you want to hear more about. Obviously, we touched on co-diagnosis. We could, again, do another episode. We've got them in the archives for sure about hygiene co-diagnosis. But that evolves with the technology, too, and it evolves as perio, you know, information comes out more and more. There's a conversation to be had there. You could always do what Andrew did and just hire an office manager that's a former hygienist that still has her license, and that'll be super easy to just, you know, convert your whole hygiene department.
It's a cheat code.
Super easy.
It doesn't mean it'll be easy. There's still been... I have a meeting on the books next week for a case while I was out of the office earlier this week that I was like, hey, guys, we missed this one. This should have been diagnosed.
And that's important, So, but this has been a really good conversation to bring on air. I think it kind of comes through how passionate you and I are about this topic. And like I said, we could keep going. But reach out, Caitlin at sharedpractices.com. Andrew, what's your email?
Andrew at sharedpractices.com. Pretty easy.
Could have guessed that. Yep. Questions for us, send us a note. Ideas for future episodes. If you want to hear more about anything we touched on today or other topics, we'd love to hear it. And thank you for listening. And thanks for being here, Andrew.
Thank you, Caitlin. Thanks for having me.
We'll see you all next time on the Shared Practices podcast.